this case we paint the full face with betadine.
Okay.
And sometimes I also give, paint the nose. The first painting I done with betadine.
Okay. In nose, inside the nose.
Inside the nose.
Okay.
And then the second after that I do it with our routine topical anesthetic agent.
Okay.
Okay. So this part.
Will sir open the posterior ethmoid or only sphenoid?
Yeah, it's always better to open the posterior ethmoid or do a ethmoidectomy on at least one side.
Okay.
So other side you can have only you can open only sphenoid, but from where you will routinely I prefer this side.
Okay, right side.
Right side.
Right instrument from right side and scope from left side.
No. Many times it is the surgeon's choice. If the sir, he might be doing himself only.
Okay.
Not the forehand technique. Only if you are doing only two hand technique, then you your instrument and everything will go from this side only, right side. So you make the wider cavity in this side. So we also trim the lower part of the turbinate in this side. And how much is the tumor? That depends on the tumor size. How much big sphenoid opening you will require.
Okay.
So if you need a wider opening, then you also do the similar things on opposite side. Okay. So as a first step, we just decongest it.
Hello.
I will like to lateralize the inferior turbinate.
Okay.
So now I will infiltrate first. Give me infiltration.
Planning for adult.
My choice for the pituitary I usually take Hadad, but sir's idea is different, so he may not take Hadad.
Even if CSF.
Yeah. So let it be his choice. So I will not prepare Hadad in the literature. Thank you.
Okay. Sir, we use hair, fascia lata and tissue glue, right?
Tissue glue also the surgeon's choice. I also don't use tissue glue if the neurosurgeon or somebody where I am doing that place they want me to use, I use. Or the patient is very well aware about that and they sometimes tell they no, then I use tissue glue. And I think Siddharth sir also is not using tissue or glue. So what I have seen so far, he used the basic things like gel foam, sometimes Surgicel, all the routine we use in a.
Will you remove both sides or one side?
Forehand technique, you must remove both sides.
Both sides. And what about MRI and CT scan?
Yeah, let me finish this infiltration. Then I go there and I show you. Okay? Once I infiltrate and repack nose, and then we go to the seat. And the same step again. I think when sir come, you ask them because it is better to have his view also. So this is a big station and another one.
Why are you rejecting over the system?
There is score here,
Okay.
so I am just keeping it ready.
Okay.
Leaders bench? Hello?
Yes, ma'am.
Yes. So I have this pen and we'll wait here and we'll take a look on the CT, as per how much I know. If you know any, if you want to any detail, you can also in between add the detail. Coronal cut રાખવાનું. Okay, CT નો coronal cut રાખવાનું છે ને. ચલો, then we have the first image. મને બતાવો ને એમાં શું દેખાવાનું. So this is the MRI. Okay. Hello. Yes. So this is the MRI plate, and this is the T1 image, and with contrast. And they have done some fat suppression. So MRI, it's for us, it's always we find it's difficult to read because we used to see the CT scan. So the hello. It's always confusing for us to read the MRI. So because they have so many sequences in MRI, so they add on confusion to us. Because in T1 the structure appear different and T2 appear different, and if we usually what I do is I just don't see the T2 image, I just concentrate on T1 image. Okay, so one image if we can read properly, then also it's proper. So what we should see in T1 image, how we can differentiate. So the basic difference in T1 and T2 is you will see in T1 the CSF, your bone, and your vascular structure in which the blood is continuously flowing, that will appear. Na CT scan par image. So the CSF, okay, you see here.
Yes.
The CSF will appear black.
CSF is dark.
Dark.
Yes.
Yes, dark. The air will appear dark.
Yes.
The bone will appear dark.
Yes.
Then the blood which is flowing in the carotid vessels, that will appear dark. These are the carotid.
Yes.
Okay. So this will help us to read the MRI. So the air, bone, CSF, and flowing blood, that will appear dark. Okay. So this carotid, the blood will appear dark.
Yes.
Now the second thing, the brain, white and grey matter will appear greyish. Okay. And the pituitary tumor also will have same density compared to the brain tissue. Okay, so this is the tissue, and this tissue will appear like this. Now there is the whether it is a homogeneous or it is heterogeneous, so that will depend on the pathology. But usually the pituitary we see a homogeneous thing. And when we do a contrast, your pituitary gland will enhance. And in T1, how to differentiate the anterior pituitary and posterior pituitary. Okay, anterior lobe and posterior pituitary. Okay, so mainly the most of the tumor is in the from the anterior lobe of pituitary. So when it is a normal scan, then it is easily you can differentiate between the two normal pituitary and macroadenoma. Okay. Hello. Yes. So when the tumor has grown too big, sometimes you may not get the normal pituitary gland. But you see on this sagittal scan, so the posterior enhancement you can take it as could be a normal pituitary.
Is there any difference we found in hormone secreting or non-hormone secreting tumor on MRI?
MRI usually that don't give information about the hormone secretary or not. But we have to differentiate between microadenoma. This is a macroadenoma, so that's it's not a problem. But if it is a microadenoma, then they do a contrast, and what happens when they give the contrast, the normal pituitary gland will enhance, but the microadenoma part will not enhance first. So that a particular spot will appear as a non-enhanced if they have taken the cut CT in early phase after giving the contrast, and in late phase when the enhancement is going, then the microadenoma will appear hyperintense in that case. So that how we can catch the microadenoma with MRI. Okay? Hello?
Yes.
So now for starting the pituitary case, what we need to see, the first we as a ENT surgeon we have to see our body corridor whether any septal deviation is there or not, because if we are planning the hadad, what difficulties we may take. So if you are planning hadad, usually I prefer to go on the deviation side and take the hadad from that side. And another thing we need to see is the pneumatization of sphenoid sinus. Okay, so it is a conchal, a cellar or post cellar. So if it is not pneumatized well, then it's become difficult to go through a transnasal route. Then the cellar pneumatization is okay. You may have get a pneumatization up to the cellar floor, and when it's go the beyond in extend into the clivus, it's called a post cellar pneumatization. So if the sphenoid is well pneumatized, it is helpful in nasal transsphenoidal surgery, pituitary surgery. Now, after seeing the sphenoid pneumatization, you can in CT scan you can see the widening of sella, the tissue coming down into the sphenoid sinus. That also confirms your diagnosis. Then you can see the anterior glenoid process and the area of internal carotid and optic nerve. You can have the how is the anatomy, how it is replaced. You can have an idea. Now again coming to the MRI cuts, coronal cuts, T1 MS. So usually what the surgeons interest when they are doing the transsphenoidal surgery, so they are interested in looking the where is the carotid. Okay. So we can go from anterior to posterior or search from posterior to anterior. So in this, so any cut if you want to read, you can go either this sequence or you can go from back to the front. Okay. So I would like to go from back to the front. Okay. So this is the clivus area or last this is the brainstem, then here the sphenoid is starting. So if we see the carotid, it comes from the carotid canal, then it is the petrous part of the carotid in the temporal bone, and then it's come out from the foramen lacerum and then it's ascend. So there is the petrous carotid, there is the posterior chain of the petrous carotid where it goes up. Okay, so that is the area of foramen lacerum and where it takes the upward turn.
Yes.
So then it's take the upper tongue and it's for the anterior genuopitras carotid. And also the same area that going upward in the sphenoid sinus, this one, that is called the paralival carotid. Okay. Then there is the petrous carotid convert into the
Your hand is on.
okay. Then this petrous carotid go up and then it's turned into the cavernous carotid. That is the horizontal part of the carotid. Okay. So the cavernous carotid comes anteriorly as horizontally. Then again it turns up. So this lower down is the horizontal part of the cavernous carotid. Then it turns up and it become a clinoidal carotid behind the anterior clinoid process. So you should see two arteries here. So this is the same carotid artery, horizontal, and then the clinoidal segment of the carotid artery. So so this is the cavernous sinus. So we have idea that this is the area of cavernous sinus. Okay, both sides. So mainly the tumor is on the medial aspect of the carotid. So it's may not be engulfing or going much deep into the cavernous sinus. Now then after clinoidal carotid it goes up and it gives the branch the anterior cerebral artery and middle cerebral artery. Okay. So I think if you trace here this could be the middle cerebral branch and this could be the anterior cerebral artery.
That I think hypophyseal artery, superior and inferior.
No, inferior hypophyseal artery it comes at the petrous part near the foramen lacerum when the petrous part goes upward. So it is in lower down. Then this is the lesser sphenoid. Now we have to see the optic nerve. Okay, so we can trace the orbit posteriorly.
Focus karo. Please right over.
So we are tracing the orbit posteriorly. Okay.
Okay.
So here it's over.
Okay.
So here could be the orbital apex.
Okay.
And the area of superior orbital fissure, and this could be the optic nerve. And better way to see it, this is the optic nerve. Okay, this is optic canal and optic nerve. So its optic nerve is also away from the lesion. And is this patient also not having any vision problem? So this was the interesting patient. The patient actually came for the watery nasal discharge. And on MRI we found the pituitary tumor. He had no any other symptoms there except the CSF leak. And vision is also normal. So when the vision and everything is normal, then as a surgeon you should be careful that you not give damage the optic, or when you are trying to do a tumor removal. If patient has already lost the vision, then there is a chances of improvement. But when the vision is normal, then we have to be careful. And I couldn't get the hormones are normal. Hormones are within normal range, except the patient is diabetic. I'm not hearing it properly. Can you speak loudly?
What is the probable CSF site of leak?
Yeah, because the too big tumor we can't. When will it may be, see if there is some supracellular extension here we are seeing here. So from this area, it might have reached the arachnoid. So that could be the possible. You can do a cysternography if you want to go to be more precise and that. But I think it is already tumor. We are going to explore it. So that is the we'll see when we'll open.
And would it be a posterior fossa leak?
Posterior fossa. From here you see.
Yes.
Yeah, so it might be possible. We are not sure. Okay, we see on when we'll open, we'll remove the thing. So ultimately, it doesn't. If it is coming from the pituitary tumor area, anyway the repair will remain the same.
No. Does
So
the
that-
preoperative planning change?
For me, it doesn't make any difference because even during we are removing the pituitary tumor, we find out we have a CSF clip during the removal time. So we can take it as the same. So that doesn't make much difference to me.
No. I mean, would you consider these as a benign tumor or malignant?
Oh, aggressive and malignant. You want to say that? Yeah, it could be aggressive tumor. So because it has reached the, I think, supracellular extension, that could be aggressive tumor. For the aggressive tumor, I have read in one book. That is the chapter written by the neurosurgeon. So what he feels that he divided the macroadenoma into